Morena te whānau, manuia le taio, manuia le vai aso o le ngangana Samoa, Happy Samoan Language Week whānau, tēnā tātou ne ratimihi nunu kia koe te tiamana, tā tātou tiamana o te pōri kia koe e Kim, tēnei te mihi nunu kia koe, koutou ngā, kia tātou ngā memo o te puari o Hauora Tairāwhiti. Kia koe hoki e Jim, koutou ko tātou kaimahi, kai hāpuri i roto i a Hauora Tairāwhiti, me ngā kaimahi i roto i ngā rōpū hauora o te Tairāwhiti katoa nei rā te mihi nunui kia koutou, ngā kaimahi mō koutou mahi, mō koutou aroha e pāna ki te mate karauna. He wai, tēnā koutou katoa, me noi tātou. He io o te ora, ko koe te mauri tūturu o ngā mea katoa i roto i tēnei ao. Tukua ki a mātou te mātauranga me te mōhiputanga ki te whakaora, ngā aitua me te whakatika hoki te kaore i o ritetanga o te wahinetanga me te tānetanga o te ao tūroa. Nō te orite o ngā mea katoa. Nō reira, tukua ki a mātou te māramatanga o tēnei mauri orite hei painga mō te ira tangata, me ngā aitanga maha o te pūtaiao, te ao tūroa me te ao wairoa. Homai ki a mātou i tēnei wā te kā ki te whawhai pai. Homai ki a mātou te kaha hoki ki te whawhai tēnei naue o te mate karauna. Tukua ki a mātou whānui te mauri toiora, hauora, waiora me te mauri ora hei painga mō te whānau ora. E o waiora, ka rūrui a koe ki a mātou te waioro e te whakaora, e nāia nei tai atu mō ake tonu atu, tuturu mai, kia whakamaua kia tīna, haumi e hui e, tāi ki e.
Kia ora, thank you Josh, and morena everybody, morena to those in the office.
Morena, Kim.
It's good to see everybody again, even though aha ko kare tātou a kanohi, rorohiko rānei, so morena tātou. Welcome to the members of the public who are joining us on YouTube today. It's a pleasure to have you with us. We have an hour scheduled for this public session this morning, and then we're moving into a session with some technical advisors on one of our capital projects. So we will kick off with the public session. I don't believe we have any apologies. We're just still awaiting Amy to join us, but we'll pick her up when she arrives. Can I ask item 2.1, does anyone have any conflicts to update for the Register of Interests? Carl? Thank you. And 2.2, does anyone have any conflicts in relation to any agenda items on today's agenda? Ka pai. So item 3.1, the minutes of our previous meeting that we had on Zoom. We can take the minutes as read. Does anyone have any comments or amendments to the minutes? Carl, thank you. Then we will move to adopt the minutes of the public session.
That doesn't work.
Okay. Not quite sure what that was. Sorry.
That was a loop feedback.
It was a loop feedback. On any matters arising from the minutes. So I did note in the minutes that one of the things that we have asked for is for Peter Brown to come to a meeting and update us on Māori responsiveness, particularly during COVID. Is Peter with us today?
No, apparently I asked him to come and then I changed my mind. That is mute, that's right. No, apparently I asked him to come and then I changed my mind.
No, it's on here.
But why is it? Is that one there?
Because you're,
okay.
this one's on.
We can hear you, Jim.
I might have to
join this one when you need to share.
Yep.
Yeah.
Fixed it. Okay, that's better. No, it's not. It's not.
No, we can hear you, Jim. Okay, so we might log in to see if we can have an update with Peter at our next meeting.
Yeah, sure.
Thank you.
Yeah, that's better. Stopped.
There are no live action items in the public agenda and no correspondence. So Jim, if I can pass to you to take us through the performance dashboard at item 6.1, please.
Yep, sure. Still to define the agenda. Yep. Yeah, I think some of the issues in relationship to the dashboard is showing the effects of COVID-19 effects on the hospital. So some of the indices are looking better as a result of that. I'm not sure why that is echoing so badly. Can other people hear that?
That's better. There is a bit of
yeah, but is it picking? I don't know. Anyway, sorry, we just seem to be having yeah, it's better now. Yeah, so some of the indices on there are showing the effects of COVID-19. So there are some improvements in some and some deteriorations in others. So it will be difficult to compare those over the coming few weeks and months to what was happening before. For instance, in immunisation at 8 months, that is down in those figures there. And it talks about in my report there around the fact that we had people who were quite quite concerned about taking their children out at this, to get immunised at this time, and so made the choice not to do that. And practices were also not encouraging people to come in. So we've got a bit of a catch-up program going on to improve that situation there as well. But there's some others that have bounced back quite well in terms of smoking advice for people within primary care. You can see the significant reduction in the numbers of people coming through the emergency department. And I just was looking through, so I highlighted some last night. We will talk about it a little bit later on, but we missed one person around faster cancer treatment. I don't know the details around that. So that was just 1 out of 3 in that month. And then others, like on the second page around our bed utilisation down to 41%, which would be a record low, and combined with a number of discharges. First specialist assessments, I know we'll want to have a conversation about that later on as well. So generally just sort of really showing that some of those indices are improved and some are behind. One that I think will change quite a bit is ambulatory sensitive hospitalisations will show a marked improvement over that time.
Jim, the advertising campaign that was kicked off around childhood immunisations, have we had any feedback from the ground that that's having an immediate effect, or will that not flow through to the data till next month? The
data won't show that till next month, but the feedback is that that is starting to get people, plus the extra work that's going on in terms of immunisation outreach, and the practices gearing up again is really starting to have an effect on that already.
Sorry, Jim, I missed the last part of what you were saying. My dog was barking at someone. Can you just give us a high-level outline of our planned care recovery program?
I can. Yeah. So in terms of planned care, we are already starting to gear up again. Last week we this week we're at 92% compared to the comparison week last year. So I got some figures there that we are up to are gradually improving, and we expect that the only really major component of our planned care that hasn't been reinstated, that will be joint replacements, and they will be commencing again in the week of the 8th of June. We have left the more complex procedures off until last, so that we can make sure that we're not bringing people back into a situation where there would be a chance of them becoming infected with COVID-19 or putting additional pressure on our services at a time when we may need to scale up. But clearly, the risk of that is diminishing day by day, week by week, and so it's timely now to get that back. And we are intending to increase our production, so to speak, of joint replacements by 50% for the next 6 months, and we expect that that will mean that we will catch up all of the backlog in relationship to joint replacements within that period of time. The Director General has made a challenge to district health boards to catch up on volumes by the end of this year, and that is a challenge, but we as in other DHBs are rising to that challenge of his to do that. We've seen the numbers of people waiting for first specialist assessments increase by around about 20%. Those people waiting over four months increased by about 20% over this time, and a doubling of the number of people waiting for surgery over that period of time. The difference between the two is that basically we've only been doing extremely urgent surgery over this period of time, and elective or planned care surgery is not in that category. Whereas for first specialist assessments, because our consultants were able to devote more time to that, they were able to complete a number of virtual or telephone or video consults with people, so we're able to keep up to a certain extent with the demand over that period of time, not completely. So we do plan to catch up in around about the next 6 months. We're very mindful of the fact of making sure that we are in contact with people to see what is happening with them. So we're actually going to be ringing through lists of people to see what is happening with people, to assist us with actually prioritising and getting those people back in and their procedures performed, or their first special assessments performed. Yeah, and so that's where we're at with planned care.
Thanks, Andy. You have.
John, can I just ask what's happening with stroke people being thrombolised? Because it's been zero for the last couple of months. Is that a data issue? Because I know Andrew used to have to manually do it.
No. That's reflection of the fact is there is very few admissions of people with stroke over that period of time, and then roughly 10 to 15% of people who have stroke are eligible to be thrombolised. So we can go have a month without, so 2 months in a row is not unheard of, but definitely thrombolysis is still there. Code stroke in ED is still definitely there.
Andy.
Yeah, thanks for that, Jim. You did mention that we'd missed one on the fence for cancer treatment, but it's down around 67%, which is an expectation around COVID. But I did ask last time whether we'd have a strategy to pick that up a bit quicker, because one would assume that the rate of inputs is probably staying similar. So, we don't want to stay at that sort of level behind all the time. So have we got any strategy to pick that up a bit quicker?
So that stat is 1 out of 3. So that's why it's 67%. So one person didn't meet the 62-day pathway in that month. I don't know the details about what happened for that person. We can't presume it's got anything to do with COVID-19. It may just be some circumstances in relationship to the care of that person. So we do need to investigate that one further to see what was happening there. But generally, we are hitting well above the 90% mark for month by month for faster cancer treatment. In the past, we had issues around ensuring, particularly where people needed procedures such as diagnostic procedures out of district. We spent a lot of effort working with our colleagues at Waikato DHB in particular to be able to make sure those pathways flowed well. And we've pretty much got those sorted out now. So The fact that we miss people on 62-day pathway is more of a rarity now, and something that we obviously always follow up to see what might be happening. Yeah, so I expect that will absolutely return to normal now that we're past the COVID-19, and it may not even be COVID-19 that was the problem with that particular person.
Yeah, it's probably a question around timeliness of treatment. You know, don't want that to slip out too far. Yeah.
No, well, the 62 days is a combination of time to diagnosis and time to treatment. So it's made up of 14 days from referral from the GP with high suspicion of cancer to having a first specialist assessment, 30 days to be diagnosed, and 30 days after that to be able to be to commence treatment. So yeah, that's what we're aiming for, and on most occasions that's what we achieve.
Does anyone have any further questions on the performance dashboard? Rob, your audio isn't working very well for you at the moment.
It's the questions down the other end of the table. I think it's because the microphone's far away.
Yeah.
It's when Heather asked your query, I couldn't quite hear.
Yeah, I think it's
probably
one of the hazards we're going to have with social distancing the meeting. Okay, so thank you, Jim. If there are no further questions on the performance dashboard, sorry, I'm just flicking between screens. We will move on to the chair's report. Oh, that's me. That's my report. Sorry, I was reading that as Chief report. Okay, so I did just want to take the opportunity to make a few comments around the last few months, and just to really, I just really wanted to make sure that we all have got a really clear view of exactly where we're at the moment. So our last 3 months in the DHB have been really focused on preparing for the COVID pandemic to arrive in New Zealand. So that was our focus in March, managing our local response in April and May, and now during May, resetting ourselves in order to step back up our clinical services. And I really want to take the opportunity to pay real tribute to our health workforce, both in the DHB and also our iwi providers, our primary care settings, aged residential care, our workers at the testing sites and at CBAC, and wider carers in the community. And alongside the health workforce, I also really want to pay tribute of the DHB to others who have protected our regional boundaries, those who have enforced the level 3 and level 4 restrictions, our workers who have ensured maintenance of essential services and supply lines into our community, our wider community who have in the main largely abided by the level 3 and level 4 restrictions. And I also really want to just have us cast our minds back and pay extra special tribute to those members of our community who were confirmed or probable cases of COVID, understanding the very difficult time they would have been through, and again expressed our appreciation that they did strictly observe self-isolation protocols. Between all of those efforts, we've been kept really, really safe as a community, and I hope that the community has a high level of confidence in the wider health sector response to COVID in our region. So just in terms of exactly where we were at, going into level 2 on the 4th of May, the Ministry of Health published data across all DHBs, and for Tairāwhiti, that data showed that we have the highest per capita rate of testing across the country. We have the highest rate of testing Māori. We have the second highest rate of testing Pacifica. We have the lowest positivity rate for COVID across the country and the lowest overall number of cases. And I've just got to say, I'm really, really proud of those efforts from all of not just our staff, but our wider health sector and wider workers in the community. So ngā mihi kia koutou. We've got big challenges moving forward again, as Jim's just outlined. So we do now have our attention fairly firmly focused on ensuring that we retain the ability to respond to any future occurrence of COVID while we're winding up provision of health services and working to deliver that care that was deferred during levels 3 and 4. We're also working through our annual planning processes, which we'll talk about a bit later in the meeting. So the health sector was very fortunate to receive a really significant boost in this year's budget, but we do need to manage that funding carefully. We have received an uplift in our funding. But that said, we also still have a planned deficit, so we're going to need to look very carefully at how we manage that funding, and particularly how we lock in some of the gains, particularly in models of care that we've demonstrated we're able to act on during level 3 and level 4. We need to look really carefully at integration between community care and primary care, secondary and tertiary, and also continue to really focus on and draw off those relationships with our community partners that have stood us in very good stead over recent months. Among other things, those relationships have resulted in the DHB being invited in as a partner to the wider regional recovery planning process, and we're really pleased to be a part of that process. So it's been a fairly hurly-burly few months, but I think certainly I'm feeling now that we have stood up, we have done our community proud, and we now very firmly got our sights set, as Jim has indicated, on bringing all of our services back up and catching up on deferrals. So koina tāku, ngā mihi ki a tātou, mō tā tātou kaha I tēnei wā. Happy to take any questions.
Kia ora, Kim. Thank you for that overview. I was laughing to myself because it was verbal after trying to find the report. Listen, I just wanted to know, when you talk about all those amazing stats, and yeah, me too, all of those amazing people ensuring those wonderful stats, is that broadcast widely? Like, I was thinking as you were saying that, is our region then going to get a whole bunch of people want to come here because we're a safe region, you know, as far as holidaying,
yeah.
You know, so the impacts of having that amazing report, how will that have an overflow or on impact further moving forward within space of levels? That's all I was wondering.
I don't think it's widely known. So the Ministry of Health does publish data by DHB on testing. You have to have a couple of clicks to find it, and it's not updated very regularly. So the last update was as we moved into level 2. That was data as of the 9th of May. I think there is some mention in you know, in social media and a little bit on Māori media about sort of different statuses of different regions, but the story of how we've done in our region, I don't think is widely known, and I just wanted to make sure that we all know that story and know that I'm probably being really whakahihi here, but I feel really proud of the efforts from our team. If it makes people want to come here, well, no mic can only be good for our economy, and that's certainly where many people's sights are set now. Okay, that looks like my report. So Te Waiwaro Nuku Tai Memeha. Na isn't with us today. So we met last week. I couldn't attend the whole meeting, I only attended for the first half. So Josh, I might pass over to you to update the board on the Te Waiwaro Nuku Tai Memeha hui.
Sure, more than happy to. Yeah, thank you very much, Madam Chair. So it was the first sitting of T1 with its new board, so 2 new appointments to T1, Te Aturangi Nepia Clamp and toi mai rangi Chaffey o Pauri. Te atu rangi is a representative, iwi representative, and tō mai rangi is a rangatahi representative. Both awesome contributors, and really enthusiastic to kind of help row the Te Waiora o Nukutai Memeha waka forward, which is massive. Largely the hui was around our reigniting our strategic conversations, or Te Waiora o Nukutai Memeha's strategic conversations around what T1's future work program looks like, where it fits in the scheme of things in regards to Hauora in Te Tairāwhiti. Largely what we had started, because we both Ropu T1 and us as the board had started that prior to COVID, and it got a bit of a pause on it. So we just had our first tui last week via Zoom, and have pretty much picked all of that kaupapa back up again. T1, we're fortunate too to have Kim there in order to be able to open up the hui and have a kōrero about the board's strategic direction and where we were thinking at, and all of those kinds of things. So it was largely it was largely about getting the strategy back on track, and what's our future work plan from now. Kia ora, Rob.
Kia ora, Josh. Just in relation to that, what core priorities of T1 to ensure that the change in driving the need to address inequities? What will be the priorities and focus of T1 moving forward on that?
There were two priorities. They're similar. They're actually identical to our priorities in regards to equity for Māori and equity of location. Not only East Coast ways, but so there's an inequity in regards to access, but inequity in terms of access. So there are those. There's still some other priorities that we had kind of from the old strategic direction that we need to have a look at moving forward. So we did have some stuff in regards to rangatahi, some stuff in regards to access there as well, in regards to rangatahi Māori and rangatahi LGBTQI plus rangatahi as well. So it's about re-looking at those things and kind of having a pick through. So the formalization of those things will happen through this discussion. That kōrero that we had last week was pretty much the first. We were gearing up to start having them, and then COVID gave those things the chop. It was actually kind of a couple of steps back too, because it was also about bringing up. Now we have 2 new board members. It's bringing them up to speed in regards to what the HAPS is as well. So it was largely a kind of settling kind of conversation. Any other questions or whakaaro whānau? Oh, tukuna atu hoatu te rākau. Oh, was that a hand, Mere?
Kia ora, sorry.
Okay, te pai.
I appreciate that and that question, Rob, too, because obviously the focus on equity is still an ongoing. But I just wondered, with T1, other than knowing the terms of reference and the work that you are there, is that well resourced? Is it seemingly going to be this is a better space moving forward? I always am concerned that we have, I guess, specialist committees, but in their role moving forward and understanding huge equity issues for Māori and Pacifica particularly, and I hear you mention the LGBT, framework-wise. So I just wondered, do you sense it's well resourced in this now, based on a lot of other kind of prioritised spaces? I'm not sure, so just wondered how you felt about resourcing.
The resourcing is increasing. It's heading in the right direction in regards to resourcing T1 in order to be able to do the mahi that not only we as a board expect it to do, but also our iwi partners are expecting things to land through there. So resourcing is increasing, and again that also is kind of tied to the strategic convos that T1 need to land in order so that we can match resourcing to what the direction is that that T1 is going in, or what the focuses are and will be. But yeah, it's yeah, the resourcing is increasing at the moment. Any other questions or kōrero whānau? If not, oh, sorry, Rob.
You're on mute, Rob.
Oh,
I
I see your question. Yeah, I see your question. Yeah, the you mean our Māori health director inside Hauora Tairāwhiti?
Yes.
Yes. Yeah. So he does attend. Yeah. Again, what that resource. I liked. I'm in terms of the T1 discussions. This still focused on, okay, what are the things that we want to accomplish, and then matching the resource in order to be able to accomplish those things. But Peter was at our last hui. Any other questions or kōrero whānau? If not, hoatu te rākau kōrero ki a koe te tiamana.
Kia ora, thank you. And Nara's joining us, so thank you for picking that up. Just a wee technical hitch we had, so but he's not on yet. So thank you for picking that up. Josh, we'll now move to Jim, hand over to you for your Chief Executive's report.
Thank you, Kim. I'm going to start off with a highlight of the month for me. Has been appointment of a new PA or EA for me, Rachel. So Rachel has been valiantly helping me over the last part-time between me and Craig over the last 2 months, 3 months. Yes. And while this process has been going on to appoint a new executive assistant and, of course, board secretary. So just wanted to acknowledge the fact that Rachel has joined now, and officially next week, isn't it? Or the week after?
The week after.
Yeah. So yeah, it'll be nice to stop doing 2 jobs, won't it, Rachel? So back to the Chief Executive's report. We financially in April we had an overspend. There's a lot of expenditure coming through around COVID expenses. We are running with more staff than we would normally have, and we're still doing things like manning the front door, not 24/7, from 8 till 10 on a daily basis. Areas like that. We've also, up until when we went into a level 2, were equalising the earnings of people who were casual employees who had less work with us because of the fact that we just had less people in hospital, needed less casual employees, but we're equalising their pay, and that was another $125,000 expenditure for the month that was unbudgeted. And you'll note in there also that we made a one-off payment in the month of $185,000 to the National Haemophilia Pool. That's a pool that was put in place probably a good 10 to 15 years ago now to spread the cost of treatment for people with haemophilia across the country, to make it fair in that people with haemophilia tend to live in major centres where they can have quick and easy access, as you can realise, to treatment if necessary. So there's a gradual migration out of most areas of the country to the pool is there. But in the last, and actually in this financial year, there's been a much larger demand on the pool, on the treatment pool for people coming through that. So quite a considerable, we're paying $185,000. So you can imagine the size of the increase across the country this year, and so that has come through that month as this month as well. And later on in the financials, there is there's an analysis which shows the COVID effects as opposed to just business as usual operating expenditure over the last few months. We are still projecting to be over budget at the end of June, although we do believe that that's coming closer to budget now. inclusive of COVID, but definitely exclusive of COVID expenditure. So that is reflective of the reduced, some of the reduced costs that we are seeing on underlying the increase in expenditure from COVID preparations, and the COVID costs are starting to reduce now as we go down levels and remove some of those costs that we've been having. You can see on the graphs there that the sort of huge drop-offs in people coming to the hospital, admitted acutely into the hospital. You're used to seeing those graphs ever increasing, and now we've got those major drop-off points, record lows of people being admitted, and in all of the various specialties, particularly in paediatrics. We had very low months the last couple of months in relationship to that, and similarly people coming through the emergency department, record lows there as well. Since that time, so we were operating, hospital got down to about 30 to 40% occupancy at times over the last month or so. We're back up to 65% now, and particularly this week as we've had more people coming through for planned care surgery. Meanwhile, in the funder arm, there has been obviously that expenditure around the haemophilia, but also there's a lot of additional revenue that's coming in there for areas such as the extension to Te Kuwatawata and pay equity, with corresponding expenditure offsetting that. Our key indicators, we've already talked about faster cancer treatment, immunisation, we've also talked about that and the drive to get that back on track again. Influenza, immunisation, vaccination, we have got a huge drive on the moment to try and get as many people vaccinated, particularly older people and particularly older Māori there. We are ahead of where we have been in any prior year in relationship to that, but still have a long way to go to get up to the kind of levels we do want to get over 80% of older people and people with long-term health conditions vaccinated this year, to make sure that they are protected. We've got supplies of vaccine at the moment, so there's no hold up there, and we have had general practices redoubling their efforts to contact people and get them in. People are now, of course, able to come out of their homes and come to general practice and be vaccinated, but we've also had campaigns by both our iwi providers to get out to people in their homes or in their communities and provide vaccination for them. We've talked already.
Interrupt you there for a minute. Josh has got a question which is probably linked to this part you're talking about.
Yeah, I just had a question of clarification in regards to influenza vaccines. That the third little paragraph down, the dates are kind of weird there to me. So is that part saying 1st of April to the 4th of May this year? Not backwards to 2019, or
it should be 1 April 2019 to 4/5/2019 instead of not 1919.
Okay. Oh, right. Okay. So
that might have been figures from the flu pandemic.
I was trying to work out if it was 1st April 2020 backwards to 4th of May 2019.
No, it should be 1 April 2019 to 4th of May 2019. That's what happens when you cut and paste. Yeah.
And then the next line also has is that also 1st of April 2019?
Yeah, that should be the comparison. So it's basically just trying to compare that this year with last year, so that over 65s last year in the comparable periods we had 35% of the total population vaccinated and Māori 28%. This year we've got 53% of the total population and Māori 45%. It's really just trying to show that we're much further ahead in the program this year, but still a long way to go.
Meredith, did you also have a comment on this?
I just wanted to ask Jim, do we collect data on those who refuse the vaccination, like they get offered it because of health issues, etc., and they decline? Do we collect that data as well? And does that vaccination just get moved on to someone else who will say yes to it?
We do collect information on people who decline. And one of the things that I know that particularly Ngāti Porou Hauora are doing is going back out to talk with those people around what might be the reasons why they've declined initially, and just reconfirming for them the safety and efficacy of the vaccination, particularly this year, and the importance for them to become vaccinated. We've also asked for communities and whānau to actually support their elderly relatives in decision making, and also support them and able to get them out to be vaccinated. So yes, we do follow up for those people, and obviously there's a huge amount of vaccine available in the country this year, and although it is likely with the rate of vaccination that's occurring that there won't be enough vaccine of that initial vaccine order that the Ministry of Health has put in to vaccinate all of the non-priority people as that comes out. There is more vaccine that is being imported from the Northern Hemisphere.
Thanks, Jim. Back to you.
Yeah, electors we've pretty much talked about as well. Emergency department we've also talked about. I just put in a few graphs that I thought you might be interested in. The first one there is around people being referred in from general practice to our services for specialist assessments. You'll see the large drop off in April. I don't have the May figures in there yet, but you can see there's a large drop off there, and in fact actually that drop off is pretty much equivalent for all ethnicities. So that is really just more reflecting the fewer numbers of people coming through primary care at that time. And then the next graph is showing the rate of utilization of non-face-to-face outpatient appointments. Again, that's reasonably early stages there, but you can see a flick up in the utilization of telephone consultations with people, video conferences. I'm confident that the amount of that has increased further since that period of time, and that spike in virtual was when we did a review of referrals coming in to make sure that we were processing as many of those virtually as possible. Coronavirus specimens is just a graphical pictorial of what Kim was describing before in terms of the numbers of people tested, and it gives you the ethnicity breakdown there on both graphs, but probably more starkly obvious in the second graph there, the bar graph, where you can see that period of time there we were out in communities testing large numbers of people, and those were predominantly in communities with high Māori populations. And then a graph of the day-to-day volumes at the War Memorial Assessment Centre, and the peaks tend to be around times when there was particular publicity, and that encouraged people to come out and be tested. There's a week. Testing is greater during the week. There's always a reduction in the weekends, and I might as well talk about the CBAC now. We are the CBAC, the War Memorial Theatre CBAC, will be ending its current operations on the 2nd of June. The view of general practice is that it's time to reincorporate that practice back within the services that they provide. However, they also believe, and we agree, that going forward, at least in the initial phases into winter, that there is likely to still be, and especially at the current juncture where people are still being asked to be tested if they have any symptoms of COVID, likely symptoms of COVID-19, that there is a group of the population that normally would not be seen within general practice, people with mild respiratory, very mild respiratory infections that wouldn't be necessarily seen within general practice, that we've agreed should still continue to be swabbed, and we are looking at the most effective and efficient way of doing that. It's likely it will be a Hauora Tairāwhiti service that will be provided. We are looking to keep that going at the War Memorial Centre initially as an easy and known reference point for people, but that as time goes on, we expect less and less people will be needing that service, and we will relocate it into a different facility. it's going to be a nurse-led service initially. And so with the combination of the general practices having red and green zones within their practices and being able to triage people into those zones ahead of time from their telephone conversations and into the practices, they will be able to safely provide services for people across the spectrum and swabbing if necessary, alongside the assessments and treatment programs for people coming through with respiratory conditions. And in the interim, we as the DHB will pick up what is affectionately now known as the pink zone, which is for people who have mild symptoms or no, occasionally I would think no symptoms and still require a swab. So that's the plan going forward. So the era of the formal CBAT will end on the 2nd of June.
So can I just check in on that to make sure that we will have a good communications campaign so that our community knows in advance when and where any relocation of testing will be?
Yes. Yes. I mean, effectively, what is happening now is that people are still being asked to contact their general practitioner in the first instance, so they will still continue to do that. The general practices will triage and for people that they would normally see within general practice in the winter, they will still see them, and people will be asked to come down to the practice. For people who normally the message would be, best way to manage this is to manage that at home. Keep your fluids up, take paracetamol, and if your condition changes, come and see us. While there still is the request that those people are swabbed, those people would be asked to come to the pink zone for testing. We will be thinking of a better name than pink zone for the public.
We probably won't do that communication immediately in terms of a shift, because that may be confusing for our community. Yeah. We're working with Tony on what that might be.
Yeah, no, I think time for when it happens, but so that people aren't arriving there and wondering where to go.
Yeah. The next one there,
sorry.
Yeah.
Just a question. What's the status of the CBAC Centre at Ngāti Pura Hauora?
Yeah, sorry, I was going to, I should have updated there. So Ngāti Pura Hauora on a similar track to wind up the formal CBAC function that they've had there. They've actually scaled that back very considerably in recent weeks as well. The numbers of people coming through that centre is very, very low. So they are going to incorporate that back within their usual operating, but making sure they have appropriate streaming of people coming through.
And Meredith's also got a related question.
Yeah, Jim, in respect to some of those graphs, especially the one around the teleconference virtual kind of space, I know that we've talked earlier around key learnings throughout this COVID time in regards to our community accessing health, be it through a phone call, a teleconference, etc. So are those key mechanisms moving forward that will be looked at? Because considering equity for those whānau that don't have strong access to Wi-Fi or connection of that ilk. So I see the benefits, of course, if we can get people being able to phone in and have a discussion. That means they take some paracetamol. You'll be fine if you stay home. But is that something in the key learnings moving forward? We're going to see a lot more of the virtual medical kind of professional help. And is that a strategy space where currently talking more to? Just looking at that graph, I was just wondering about that. Kia ora.
Yes, absolutely. And I've got a few points towards the end of this that I was going to talk to, but that's definitely one of them is around the new normal and how we operate differently. There's what you've just talked about there, and that graph is a really good example of that. To take the learnings, what we've found that it works very well for people, both the clinicians and the patients, to be able to have this opportunity. One of our clinicians travelled up to the coast last week to specifically work with Ngāti Pura Hauora around the setup of a more extensive network of telehealth consultation facilities across the whole of Ngāti Pura Hauora. Those facilities have been in place, but they haven't been activated. And now we've got the drive and knowledge that this works well. And so they have been activated now, and our clinicians will be able to carry out video conference consultations with people in Tairāwhiti, for instance, through the clinic there in Tairāwhiti. So they will need to come into the clinic, but they won't need to, on occasions, obviously some things will still need to come down here to Turanga, but some people will still need to be able to have those video conference consultations in places like Tairāwhiti. Now, what we know about that is that it does require organisation. It does require a different way of working for people at this end and at that end, and obviously it requires a different format for the patient. But where the consultation can safely take place without the need for any physical examination, then that is of preference, and our experience is that patients find it preferable to be able to do that, and so there's no barriers from that aspect.
I think you raise a really good point, Meredith, that we're probably going to want to have quite a talk about at some point, and that is the what are the great things that we have learnt out of this that we can now integrate into what becomes our new normal. And for me, one of those is just seeing how so many people could rally around a single kaupapa and make a real difference. And I think that's a whole that whole community effort has been a really telling thing for me. Jim, is that drawing the end of your report to a close?
There's just another couple of quick things I just wanted to mention, please, Kim. Just to highlight the staff vaccination rates, we'd have stupendous effort there. That's already surpassed any previous total. If you remember, we're the highest vaccinated staff rate in the country, and we're hoping that we'll be able to retain our #1 spot on that as well. I've just put a few dot points in the bottom there. I won't go through all of them, but just highlight the piece around the annual plan that needs to be back down to the ministry by the 22nd of June. Obviously, there won't be a chance for the board to sign that off at another meeting, so we do have to have some process around gaining the board's approval around that. Clearly, the financial component of that is going to need some considerable work to change that from what we've had previously, and so we need to be able to communicate that. So we need to probably later on in the meeting have a conversation about how we will be doing that. The other one that I just wanted to highlight as well is around the report that was done from Waitemata DHB around the incidences there where a number of staff became COVID positive in the course of their work. And there are a number of learnings that we have gleaned out of that report for our own purposes, and we'll be utilising that, particularly around the utilisation of N95 masks and the systems and processes that need to be had around that. That's a common theme across the country, and a piece of work to be able to be done there. And the only other one that I would just want to mention at this point is around reconfiguration of the hospital. That's another piece of work that of learnings that we've had from the COVID-19 experience. We had actually started a process around that prior to COVID-19, but it's really confirmed to us that the way in which the wards within the hospital, adult wards within the hospital, are configured is not as optimal as we could have it. And so we're about to launch a consultation process with our staff and unions and other parties to look about how we would do that differently going forward. That's me.
Does anyone have any further questions of Jim on his report? Okay, Craig, I will pass to you if there's any further matters on the financial aspects. And okay, I was just going to ask who this person who's joined us was. It's one of our technical advisors. Kia ora, welcome. So we will be shortly moving to the discussion on the capital project and the architectural considerations. But while we're still in the public session, I'd just like to finish off this part so that we don't have to stop and then start streaming again. So Craig, are there anything you'd like to highlight on the finance that we raised?
Just a couple of points. Yeah, so take the paper as read. Adverse for the month 359, 358k. Of that, you know, we had COVID-related costs of 150 that we're paying to casuals to rebalance them through this period. 40k of additional payments to ICU staff, 10k for additional cleaning, plus our traditional accrual. Year to date, we're 2.1 million. Adverse to budget. Of that, we've got 1.5 million of our non-specific accrual, which is non-budgeted. Probably moving over, it's good to see our balance sheet is in a positive position. Net working capitals. We've got funds in the bank now. And moving over to page 33, which is our forecast business, which splits out our COVID costs and non-COVID costs. So still tracking at the stage for just over 2 million adverse to budget for the financial year. To mention earlier, we do see some upside on that, particularly around IDF outflows. We had a swing in the month for about 600k to Waikato DHB. And just conversations yesterday, we've seen some potential good upside there. So working back to budget. So that's just splitting out our forecast BAU to year end and forecast COVID costs. So we can see a big delta, 786k adverse to the revenue coming in for COVID related spend. Thank
you.
Any questions on that?
It's not what we wanted, an extra $700,000 spend, but it was a necessary thing that we had to do, and we all knew that going in, that this was something that we just needed to do. So are there any questions on Craig's report? If not, then I think our next item is reports from board subcommittees. So as we all know, subcommittees have largely been deferred during COVID and coming through, issues coming directly to the board. However, the Finance, Audit and Risk Committee did meet. So Rob, can I pass this one over to you?
Thanks, Kim. Yep, we met last week, and one of the reports we had back was from our health share auditors, who are leading an internal audit program. And so on page 35, I just wanted to raise, and it's kind of in line with the other paper that we've got on our agenda today in terms of the board skills report, is the opportunity, and I'm really seeking support and approval and agreement amongst us board members that we look at what's been proposed as training specifically for governance on implementation and oversight of all privacy issues. So that's really the only thing, and then also acceptance of our revised terms of reference, Kim. So just the two matters, and hopefully we can have a discussion on those two things. Kia ora.
Ka pai. So on the governance, we can kind of pick that up in the next item, but just to note that there is a governance development program being driven out of the ministry that once we have a considered process of what we need, we will be able to tap into both as a board and as individuals for particular things that we think need developing. Did you want to talk about the things like the privacy training now, or shall we put those out into the when we talk about the wider governance structure and issues in public excluded?
We can leave the training until we talk about the board skills report, and then really that second bit is the changes to the fact that we've moved information to a separate committee. So this is all part, the revised terms of reference is about our new proposed structure. So if we could just get approval from the board for those revised terms of reference.
Ka pai is, can someone move Rob's proposal? Rob will, and seconded Josh. Ka pai, thank you. All in agreement? Thank you. That is adopted. Thank you, Rob. So on to our next matter on the agenda is the COVID recovery dashboard, Jim.
Yes, so that is a device from the Ministry of Health to provide us with information around our recovery, as the name would imply. Unfortunately, the data is, because they are getting that from the national collections, their input of data is rather slow compared to our own local ability to track what is happening on a day-to-day basis or week-by-week basis. So their picture will always lag behind. But it's useful in showing how we're going to do. So we will see that gradually improve further as the weeks go by. But I think it's most likely that we will be able to provide the board with information more up to date to that on a monthly basis, because it takes time for us to enter the data here to then go back to them down there for them to process it and then produce this report.
Jim, it's David Moore here, just so we've joined for the business case item. Would you like us to leave and come back in 10 minutes?
I think it's okay if you just stay there. We shouldn't be too much longer.
We're only a couple of minutes away.
Yep.
Thank you, Jim. This is really a FYI item at this point. This does come through regularly, and I think that the important thing that we'll want to talk about when we talk about our planning is how we are monitoring the plan for recovery of our planned care arrangements, particularly. So we might park that until we talk about our wider planning issues. So if we can move now to the board skills assessment paper. So I guess what I'm really looking for on this is just to, I think I've spoken to you briefly on this before, that the ministry have retained consultants to support across DHB's governance, including governance development and also assessment of our basically our board skills and our board effectiveness. We're required to do an assessment. The minister does require us to. And I'm actually really keen for us to develop a good understanding of where our strengths are and are not as a board, so that we can actively go about really building on our strengths and making sure that we plug any gaps. It seems sensible to me to be tapping into what the ministry has already contracted, so that we can realise some cost efficiencies here. Yeah, and I guess just the other thing is this first arose in December. The ministry first briefed chairs on this, and I think I said to you at the time that actually it was way too early. There was no way that we were ready to conduct a board assessment because we had all really just met each other and hadn't had an opportunity to work together. But now that we have, and to be honest, over the last 6 weeks, quite intensively as a board, I think we're now getting to the point in time where it would be useful for us to have a considered reflection on our board as a board and on ourselves as individuals. So this paper is there really as an option for us to look at. I'm not really expecting people to say yes, no, or here's a different alternative at this point, but just to log that we do need to give some consideration to this. I'm, if you would like me to, happy to go back to the consultants that the ministry have hired and ask them to provide us with kind of a bit more process detail of what this might involve for the board, because I'm aware that everyone is really busy and don't want to land you into something that's going to be an extreme burden on your time. But my suggestion is at this stage that that's our next step, to get a strong signal of what this would mean going forward. So I'm happy to take your views if you would like us to progress that.
It looked like a comprehensive report and program, and I think I agree with you, Kim. It would be interesting to know just how that would be implemented and what it would look like. But I'm certainly supportive of us doing that and building the capacity of this board. We've got some major issues. We've got a change at the helm. We've got a new team. I think we've got great energy and great responsiveness on the back of the COVID. And I think it'd be great to build on that capacity and just be a better board.
So I support what you've just addressed totally.
Okay, so I'll take that. I'll talk with Jim and we will take this forward in terms of process-wise, what our next step is over the next month, and touch base with the board in our June meeting about where we're going forward with this. Kei te pai tēnā. Thank you. Now, I believe that now brings our public session to a close. So before we stop live streaming, first of all, I'd just like to thank members of the public who have joined us today. We certainly found last time we met as a board, we had way more public participation in the board meeting than we have ever had around the boardroom. So we would like to look at how we maybe maintain this to keep the doors of the boardroom open to you via this virtual technology. But thank you for taking the time to join us today. And just before we close, I now need to move a resolution that we will move into public excluded for items 10.1 to 10.2, 12.1 to 12.4, and 13.1 to 13.3 as noted on the agenda, and in accordance with Schedule 3 of the New Zealand Public Health and Disabilities Act. So I'll move that we move into public excluded for those items. Can someone second that, please? Thank you, Rob. All those in favour? Ka pai, thank you. Thank you, and until next month, members of the public, thank you for joining us. IT, if you can please